Bharathi KS from Jayadeva Institute of Medical Science. She is head of the department and the chief in Jayadeva Institute of Cardiac Science, and she is also an associate professor in Jayadeva. She will be talking on the topic of perioperative arrhythmia.
This is the pointer.
I welcome Dr. Bharathi to deliver us.
So, good morning, one and all. I take this opportunity to welcome all the delegates to the Heritage City and greetings from my institute. So, perioperative cardiac arrhythmias is a vast topic. I'll try to cover it as much as possible. Firstly, the cardiac arrhythmias are the most common perioperative abnormality. The incidence ranges from 16 to 60% among the non-cardiac surgery, while it is up to 90% during the cardiac surgery. So coming to the definition of cardiac arrhythmias, it is any abnormality of the cardiac rate, rhythm or conduction. Why, as an anesthesiologist, you should know about the cardiac arrhythmias? Because it can cause hemodynamic instability, and if any arrhythmia is not intervened timely, may precipitate a malignant event and may cause a life-threatening process, and thereby increasing the perioperative mortality and morbidity. So all of you know about the conduction system of the heart. I don't want to stress upon that. So it's one thing I want to tell you, it's an amazing system where you have sequential depolarization and repolarizations, allowing the atria to empty into the relaxing ventricles and then forms the cardiac cycle. Then coming to the, a bit about the myocardial action potential. All of you should know the basis of the myocardial action potential, the different phases of it, and the ion channels responsible for it. When you have to understand and treat the cardiac arrhythmias. So here, so you have the resting membrane potential. Sorry. So the resting membrane potential of the heart is minus 90 millivolts, which is mainly because of your leaky potassium channels. They maintain the minus 90 millivolt action potential. Whenever the action potential reaches the myocardial cell, there is entry of sodium and calcium through the gap junctions in the myocardial cell. This causes the voltage-gated sodium channels to open up, and it causes a concentration gradient influx of sodium. And this causes the phase 0 or depolarization phase. So the same reduction in the membrane potential may also open up an voltage-gated potassium channel, and there is efflux of potassium. So this also opens up the slow calcium voltage-gated calcium channels. The influx of calcium plus efflux of potassium makes this plateau phase or phase 2 of the action potential. And finally, as the calcium and sodium channels are time-bound, they close, and the depolarization is because of your potassium efflux. You understand this? When you understand this, it is easy for you to understand. But the action potential in the pacemaker cell is quite different. It has only 3 phases, and the slow depolarization is because of the sodium influx, not the calcium. And the rapid depolarization in the pacemaker cell is because of the calcium influx, and the repolarization is same as in the this thing. Now, I want you to concentrate mainly to learn in this session about the mechanism of cardiac arrhythmias. Once you know the mechanisms of cardiac arrhythmias, it is easy for you to understand the mechanism of antiarrhythmics and the situations in which these drugs can be used. So there are only 4 mechanisms of cardiac arrhythmias. 1, there is any disturbance in automaticity, disturbance in conduction, a mechanism called triggered activity, and a re-entry. So one by one I want to talk. So when you talk about the bradyarrhythmias, the first mechanism of bradyarrhythmia is reduced automaticity. What happens, as you all know, the sinoatrial node, which is the dominant pacemaker of the heart, it usually beats at 60 to 100 per minute. Whenever there is increased vagal tone, as in athletes, or during sleep, or any surgical stimulation of vagus like peritoneal pull or a carotid sinus stimulation, or your sternal retraction, all can inhibit the vagus and reduce the automaticity. it can happen in few diseases like hypothyroidism, and your drugs like beta blockers can also suppress the SCA node. The second mechanism of bradycardia is conduction blocks. So these conduction blocks can occur anywhere. When it occurs in the SA node or when it occurs in the AV node or in the bundle of His, they give you first, second, and third degree heart blocks. So these conduction blocks, when it occurs further down in the right or left bundle branches, remember it does not cause bradycardia, it only prolongs the QRS. So this is the mechanism of bradyarrhythmias. So when you come to tachyarrhythmias, there are also three mechanisms. So the first mechanism of tachycardia is increased automaticity. How does it happen? Whenever there is sympathetic stimulation, say like exercise, anxiety, it stimulates either the SCA node or the AV node and increases the heart rate. Not only that, the automaticity can happen anywhere in the other parts of the myocardium. That, like for example, I'm taking the example of atrial fibrillation, where there may be a ectopic focus in the atria, which can trigger, because of its increased automaticity, it can send more impulses to the AV node. This is an example of increased automaticity other than the SCA node. Coming to the second mechanism of tachycardia, it is the triggered activity. It is, though difficult, better you understand this mechanism because in the mechanism of triggered activity, there is a term called after depolarization. It's not very difficult. Once you understand, it will be easy for you. So there is a mechanism called after depolarization, that is, in the myocardial action potential, after the phase of depolarization, during the repolarization, there can be a triggered activity. It can happen in two ways. So this can happen anywhere in the myocardium, but I'm taking the example of in the ventricular muscle. So, in the ventricular muscle, after the depolarization, in the early phase, that is, in the relative refractory period, there can be a triggered activity. This is called early after depolarization. When the same triggered activity happens in the phase 4, it is called delayed after depolarization. Why is it important for you to understand? Because, as you see, this early depolarization, when can it happen? Whenever your action potential duration is prolonged, or whenever your repolarization is prolonged, or on ECG, when you see there is QTC is prolonged, there can be a triggered activity. Now, do you understand why should you avoid QTC prolonging drugs? So, it is very easy. So, whenever your QTC is prolonged, or whenever your repolarization is prolonged, or whenever your action potential duration is prolonged, you can have a triggered activity. Coming to the second type, it is a delayed after depolarization. What happens here? In the phase 4, it is mainly because of the increased intracellular calcium. When can it happen? It can happen in post-MI. There may be increased release of calcium by the sarcoplasmic reticulum. So this increased calcium load in the cell raises the negativity of the resting membrane potential is reduced, and thus may cause increased automaticity or a triggered activity. So, where else can it happen? Your sympathetic tone. Increased sympathetic tone can also cause increased calcium load. So, now you understand why should you avoid increased sympathetic tone? So, this is the reason. So, the third mechanism of tachyarrhythmia is a re-entry phenomenon. So this re-entry can occur anywhere again in the myocardium, either in the atria or the ventricle. I am here taking the example of a re-entry phenomenon in the AV node for the convenience sake. So in the AV node, few people can have an accessory pathway. What do you mean by that? Whenever an atrial impulse reaches the AV node, it usually passes through the fast track. In few people, where there is a slow conducting pathway, an accessory pathway, this never happens with the regular beats. Whenever a premature atrial contraction comes here, that time the fast track is refractory. So the premature contraction enters the slow track. And by the time the premature contraction reaches the bundle of His, the fast track would have recovered from the refractory period, and this impulse may enter retrograde to the atrium. This may cause a circus movement or a sustained tachycardia. Usually all the supraventricular arrhythmias are the example for this. So now you understand the mechanisms. Now it is very easy for you to understand the arrhythmic drugs. So now when I say it is the class 1 drugs act on the sodium channels, you understand they act in the phase 0, in the depolarization phase. When I say class 2 drugs are the beta blockers, you understand it reduces the sympathetic activity, reduces the automaticity, reduces the calcium overload in the myocardial cell. So class 3 drugs are the drugs which act on the potassium channels. Class 4 drugs are the drugs which act on the calcium channels. So these are the drugs. Because of the time constraint, I cannot read out, but as postgraduates, for each class of drug, you remember one at least. So, and remember one thing, your amiodarone, it acts on all the channels. So that's why it's called a chemical cardioversion, a drug of chemical cardioversion. So among the drugs, among the first year drugs, remember lidocaine, it is readily available with you. Beta blockers, esmolol and propranolol. These are the drugs we use perioperatively. Of course, for the regular OPD basis, cardiologists use so many drugs, but perioperatively, you hardly use 4 to 5 drugs. The potassium channel blockers, these are the amiodarone, and calcium channel verapamil diltiazem, and 2 miscellaneous drugs you have to remember, adenosine and digoxin. So coming to what all can precipitate arrhythmias in your patient. So there are various factors related to patient, any pre-existing disease in the patient, procedure or surgery related, or an anesthesia pharmacological agent related. So we'll see briefly what are the patient-related factors. Say, example, the patient is an elderly patient. They may have degenerative changes in the SCA node or the conduction systems, which can give rise to sick sinus syndrome or tachybrady syndromes, and anxiety, caffeine, alcohol, smoking can all precipitate a arrhythmia. Coming to the pre-existing disease, a MEM patient may be a known case of ischemic heart disease or any congenital heart disease may have abnormal rhythms, a thyrotoxicosis, hypothyroidism, a central nervous system disease like subarachnoid hemorrhage can have a ST segment changes, a renal disease, and even a patient with COPD can have a RVOT, VTs. Coming to surgery related, in the cardiac surgery, you have surgical manipulation of the heart during the off-pump surgeries. External retraction can give rise to bradycardia, and cannulation of SVC, IVC, taking sutures over the atrium, and a release of aortic cross clamp can also give rise to cardiac arrhythmias. So coming to the non-cardiac surgery, the incidence is little less here because you don't meddle the heart. The incidence is 18 to 20%. Again, most of them are supraventricular in origin, but you still have more arrhythmias because of the vagal stimulation during your non-cardiac surgery, like traction on the peritoneum, oral surgeries, dental surgeries, and carotid surgeries, and laparoscopic surgeries can cause both the increased vagal tone as well as the increased parasympathetic stimulation because of your hypercarbia. Coming to the anesthesia-related factors, you have direct laryngoscopy, tracheal intubations, and during general anesthesia, if you are maintaining lighter planes, that can cause a catecholamine increase, giving rise to hypoxia, hypercarbia, as well as the electrolyte imbalances. And regional anesthesia, again, can cause a pharmacological sympathectomy, like in high spinal blockade can give rise to bradyarrhythmias. And again, central venous cannulation can stimulate the carotid sinus, or the catheter may irritate the right atrium, giving rise to arrhythmias. So now, what all the anesthetics which can cause the arrhythmias? It's a long list. It is definitely not possible to read out everything. But as all of you know, the inhalation agents can cause junctional rhythm. It is mainly by antagonizing the calcium and increasing the depolarization, as I have told you. So other things I may not be able to read. Just remember that's propofol, succinylcholine, vecuronium, local opioids, and clonidine, dexmedetomidine. They all cause bradycardia, whereas pancuronium and ketamine are sympathomimetic, and they can cause tachycardias. Not only this, you have to remember whenever you are using antiarrhythmics during the perioperative period, it may have interaction with your other drugs, anesthetics, or your pharmacological agents. What do they cause? Say, for example, adenosine. It may potentiate the effect of vasodilatation when used in general anesthesia along with isoflurane. It may worsen the vasodilatation because of your neuraxial blockade, or it can worsen the bronchoconstriction of neostigmine. Similarly, your digoxin when used along with diuretics, may increase the digoxin toxicity. It may potentiate the effect of bradycardia because of your halothane, succinylcholine. Similarly, your lidocaine, it can potentiate the sympathetic blockade. So all of you, because of the time constraints, we cannot go to each and every detail of it, but all of you, the pure postgraduates, have a list of the drugs which can increase the QT interval. As I told you, the drug in a patient who already has a QT prolongation, or whenever you use these drugs which prolong the QT interval, you may precipitate an early after depolarization and hence a torsades. So is it, are the drugs commonly used? Yes, very commonly used. They are the pre-anesthetic drugs like glycopyrrolate, your ondansetron, metoclopramide, and regular antibiotics like azithromycin, clarithromycin, your inotropes. So many of them cause the QT prolongation. So this is about the, so just for the postgraduates to look at the ECGs. Can I have a few more minutes so that I'll just show the ECGs for the postgraduates. So when you see here, when you calculate the rate, the RR interval, it has got more than 6 large QRS, large squares. Rate is 50. It's nothing but a sinus bradycardia. So the causes, management, treat the underlying cause first. If there is any hypoxemia, handle it, and then you can give the drugs as per the sinus bradycardia algorithm. Atropine, isoprenaline, dopamine, and adrenaline are given in the algorithm. But a word about the percutaneous or transvenous pacing. Now that the AED defibrillators are available in all public places, as an anesthetist, you should know, but by using the AED paddles, you can pace the patient. Though the chest impedance interferes, it is not reliable, but still you can buy time till the definitive help arise. So you have to pace the paddles and change it to the pacing mode so that you can transcutaneously pace the patient till the help arrives. Of course, the definitive pacing is by transvenous, by pacing the RV. And we do use epicardial pacing in our cardiac surgery regularly. So this is a PAC. It's a premature beat followed by an incomplete pause. The corresponding systolic wave is smaller. So here, so what are the causes? It can be a normal patient, or when it is usually self-limiting, you don't need any drugs for that. So can you identify this rhythm? Your PR interval is prolonged. It is more than 0.22 seconds. It's a first-degree heart block. So coming to this, you have progressive prolongation of PR interval with a missed beat. This is the Mobich type 2 block. Here, you have no progressive prolongation, fixed PR interval with missed beats. This is the Mobich type 2 heart blocks. So usually the treatment is, like if the patient is symptomatic, follow the bradycardia algorithm. So this, here you see many P waves and less number of QRS. The PP interval is fixed. The RR interval is also fixed, but they are not following each other. So rather we can say the PP interval is fixed, RR interval is fixed, but variable PR intervals. This is pathognomonic of your third-degree heart block. Of course, this needs pacing. So coming to, this is the most common arrhythmia you see during general anesthesia. It's a junctional rhythm, absent P waves. P can be altered morphology also. So this is the most common arrhythmia you encounter during your practice. It is the normal-looking P wave, normal-looking QRS, rate is more. This is the sinus tachycardia. Do you treat it? You treat the cause. Don't treat the cause first. What may be the causes? If it is due to pain, give adequate analgesia, hypovolemia, anemia to be corrected. If there is inadequate depth, you deepen the plane of anesthesia. And the patient related. If the patient has simple things like fever, give paracetamol. Procedure related. If you are doing laparoscopy, correct the hypercarbia and reduce the sympathetic activity. And remember, the sinus tachycardia may be an ominous sign of anaphylaxis or a pulmonary embolism. So this one. So here you have increased rate, you all know, but P wave is not very obvious. So narrow complex tachycardia with no proper P wave, you can classify it as supraventricular tachycardia. Because of time constraint, I cannot talk about the various types of supraventricular tachycardia at this level. for you to understand if it is a supraventricular tachycardia, it should be fine. What is the treatment? If the patient is not elderly, you can try some carotid massage. If the patient is elderly, try some eyeball pressure. Or if the patient is been ventilated, you can give Valsalva. The definitive drugs are adenosine. One thing you have to remember, you can give a 6 milligram IV push. How do you give? Through the central line or as nearer to the heart as possible. You can put a cephalic, you cannulate the cephalic vein, fix a 3-way, load adenosine in one syringe, load flush in another syringe, turn the 3-way, give adenosine, give the flush, lift the limb. This is how we have to do because adenosine has a very short half-life. Other drugs can be used, of course, the calcium channel blockers can also be used. So this arrhythmia, the most commonly encountered atrial fibrillation during cardiac surgery. Now again, the treatment of atrial fibrillation is very, very tricky. It depends on whether the atrial fibrillation is of new onset or a chronic onset. In a patient with chronic AF, never try to correct the rhythm. The patient will be in atrial fibrillation only. You can only control the ventricular rate by giving drugs like digoxin, verapamil, beta blocker, and Dilgem. Why? Because of the chronic AF, patient may have a thrombus in the LA, and by converting the rhythm to sinus, you may push the patient to a stroke. So in new onset AF, of course, you can control the rate with all these drugs, or you can cardiovert. Chemical cardioversion by amiodarone. So you have to know how you have to give amiodarone. Amiodarone can be given as 150 mg bolus, usually over a period of 10 minutes, then followed by 1 milligram per minute for 6 hours, followed by 0.5 milligrams per minute for 18 hours. This is how we load the amiodarone, followed by oral amiodarone. So other drugs, ibutyl and all aren't available, better be introduced to one drug which you have then followed by amiodarone. All the patients who have AF have to be anticoagulated. Refer them to a cardiologist. They need anticoagulation. Coming to this R2 appearance. This is atrial flutter with either 1:2 or 2:1 blocks. So this is a altered QRS complex. It is not normal looking. It is arising from the ventricular ectopic focus. So when do you treat them? If they are more than 6 per minute, if there is RNT phenomenon, if they are polymorphic, and if there is any bigeminy or trigeminy, like this. This is the example of trigeminy. This is an example of bigeminy. Only then you may have to treat PVCs. So what is the treatment? Lidocaine, which is available with you, 1.5 milligrams per kg body weight as a bolus, followed by 1 to 4 milligram per minute infusion. So this one, again, a wide QRS complex coming at a beats of persisting for less than 30 seconds. It's an ill-sustained VT. And this is a broad complex, QRS complex, sustained for a while, more than 30 seconds. It's a VT, sustained VT. So this is, yes, it's a dangerous rhythm. We have to treat it. What is the treatment? It's acute onset. It may be life-threatening. It can quickly worsen to ventricular fibrillation. Has to be treated. Either you can give lidocaine if it's the ischemic origin, or amiodarone can be given. So this is again your rapidly changing QRS complexes. This is the torcidus. So what are the causes? Hypomagnesemia and your drugs which can prolong the QTs. So discontinuation of the drug, IV magnesium and potassium are the treatments. Sorry for that extra time. This is the last slide maybe. So this is the ventricular fibrillation. It can be coarse or it can be fine. Follow the ALS guidelines. So any of the among above described rhythms without a pulse becomes a pulseless electrical activity. So rule out 5H, 5Ts and follow the algorithm. So this is asystole. CPR is the treatment. Finally, the management is take a 12-lead ECG. So treat the correctable causes. That is the main point. And just stop the surgical manipulation if anything is happening during surgery. If the arrhythmia persists and hemodynamically unstable, you can go for either chemical cardioversion or an electrical cardioversion. Take-home messages. So a good pre-anesthetic checkup, if you have a baseline ECG, whether if the patient already has a calculate the corrected QT interval. If the patient already has a QT prolongation, better to avoid QT prolonging drugs, maintain adequate depth of anesthesia, good analgesia, prevent hypoxia, hypotension, hypovolemia, and keep the surgical manipulations to the minimum. Okay, thank you so much for that extra time.
Thank you, Dr.